So, good morning, everybody. It's very nice to be here and see the first snow, also the winter. In London, it's been very, very warm, so this has been a very pleasant surprise to have a real winter. Now, I'm going to start off with some general remarks about what we know about the effects of terrorist incidents on people. So that'll be the first section of the talk. Okay. So first of all, let's think about the effects of major terrorist incidents on the population in general. So not so much those who are directly affected and present at the scene, but the more general population. And a lot of our knowledge of this comes from studies done in the United States after the 9/11 attacks. So it's possible that these findings could be rather limited to that situation and that culture, but nevertheless, I think they are quite interesting to read about. So over the period of the first few months, but probably not for longer than about 3 months after the major terrorist incident, such as 9/11, there was a general increase in short-term distress and anxiety that was detectable in the general population. There were some increases, for example, in drink driving offences and traffic fatalities, particularly because 9/11 involved aircraft travel. A lot of people in the United States did not stop using aircraft temporarily. They went by car, and as a result, there were many more traffic fatalities during that period than there would be normally. People also proved that there was greater sense of identification with your own country, but also with other social groupings, such as your university, for example, or your city. So people felt more national pride and sense of belonging to their own institutions. They volunteered more for charitable activities. They felt, wanted to collaborate more with other people and spending time with members of their family and people they were close to. So these were very general changes, but as I've explained, they were quite short-lived. What was not found was any increase in suicide rates or substance abuse in the general population. Now, one of the major controversies has been, can you develop PTSD, post-traumatic stress disorder, if you are many miles away from where the terrorist incident has happened? And there were reports in the US of people as far away as California developing PTSD to the 9/11 attacks which happened on the East Coast. Now, although these surveys seem to report this, when you look at longitudinal health surveys that were being conducted at the time in these areas, it's very striking that there is no overall increase in disease or health burden in psychiatric disorder during those periods. So we've got two quite contradictory types of information. One says, oh, look, it seems that all these people are suffering from PTSD hundreds of miles away, but on the other hand, there is no increase in disorder overall. So I think what seems to be happening is that people who already have psychiatric disorders have something else to worry about. They have something else to think about, something else that keeps coming into their mind, something else where the images become very important and upset them. But these are not standalone cases of post-traumatic stress disorder caused solely by these terrorist attacks. And I've not been able to find any instance in the literature of people being treated for post-traumatic stress disorder that they have supposedly developed being many, many miles away from the attacks. So that's been an interesting debate, and we must also remember that some people will develop post-traumatic stress disorder because they have a close links with individuals who they know or in their family who were actually directly involved in the terrorist attacks. So some of them will have been directly bereaved or had injured relatives, and they can account for some of this increased incidence of apparent post-traumatic stress disorder. Okay, so the next slide summarizes a number of studies. And what I've done here is to order the studies by how long they happened after the terrorist incident. So at the top, we have those with the shortest length of time, 4 days. So the measurement was done of symptoms and distress 4 days after the incident. Going all the way down, so all the way down to 241 days after the incident. And I just want you to notice from this slide that there is a very high levels of distress immediately after the incident, but this very rapidly declines as time goes on. And similarly, if you look at rates of probable PTSD in the general population, they're quite high 10 days after the incident, but they rapidly decrease as time goes on. And we can contrast this with the same figure if we look at the people who are the direct victims of these attacks. So this slide is also arranged in the same way. Here the first study was done 60 days after the attack, and the studies are arranged in the same order. So the last one measurement was taken 973 days, so about 3 years after the attack. And you can see the same pattern in rates of probable post-traumatic stress disorder occurring here, but they're just much, much higher. So from a figure of in the mid-30s, very soon after, a couple of months after the attack, but still 2 or 3 years later, we can see rates of 20 or 25% in those who are most directly affected, telling us that there is a really substantial burden of psychiatric disorder that we need to plan for in those who are the direct victims. Okay. So if we think about what those disorders are likely to be, post-traumatic stress disorder seems to be the most common one that is found, but also we have to think about and plan for other disorders such as panic disorder and phobias. We have to think about incidents of depression that's going to be increased, bereavement reactions and complicated grief in those who have lost loved ones or close others in the attacks, and increases in risky behavior and substance abuse in the context of other psychopathology. We've got some quite good ideas about who are most vulnerable among the direct victims. And here we can see that factors such as greater proximity to the attack infers greater risk to that individual, as does greater perceived life threat, greater rates of injury and death in the incident, greater availability of and repeated exposure to visual evidence of injury and death, greater infrastructure damage and loss of resources. These are all risk factors that increase the likelihood of subsequent disorders. But there are also other protective factors, previous exposure to similar stressors, greater perceived support, and greater economic resources all tend to confer a greater resistance to developing disorders. Okay. Now, what do we know about help seeking after major terrorist incidents? Well, we don't know a great deal, but for example, studies done after the bombing in Oklahoma City showed that 69% of people affected received an intervention. And after a bombing in Paris, not the recent one, but one that happened about 15 years ago, about 74% received intervention. But we know very little about what this intervention consisted of. It may have only consisted of a very brief contact or psychological debriefing. We don't know whether what was offered had any evidence base, how effective it was, or whether the effects lasted. So the evidence base is really very limited about how much help people get, despite the fact we know there are likely to be a high rate of disorder. We don't know what happens to those individuals. In the 9/11 studies in the USA, there were significant extra treatment costs in the 2 years after the 9/11 attacks. But interestingly, these were mainly accounted for by patients who had previously received psychiatric treatment. So people who had previously had psychiatric treatment went and got more of it after 9/11, but people who had not previously had any psychiatric treatment did not seem to show any increased use of treatment resources. And the main reason that people gave for not seeking treatment was that they didn't believe they had a problem. In other words, they weren't familiar with the symptoms of post-traumatic stress disorder. They found it very difficult to know whether what they were experiencing was normal, whether there was a treatment available, and what they should be doing about it. And 6 to 9 months after the 9/11 attacks, only about 1/3 of residents with probable PTSD or depression had actually sought treatment. So really, I think we must see this as a failure of the system to actually identify people, to inform people, and to ensure that they actually got the treatment that they needed. Only certain groups tended to receive treatment. They were people who, as I said, had previously had psychiatric treatment, who knew about services, they were familiar with the processes, but also uniformed personnel, people working for the emergency services. They had occupational health schemes, so they were monitored by people within their own organizations, and they were more likely to be referred for help if they had a problem. We also know now more about the time course of disorder, and there are this four distinct patterns that are commonly found after major stressful events, including terrorist incidents. So first of all, you have a group of people who are high in symptoms immediately afterwards and remain high for at least 2 years afterwards. Then we have the resilient group, who never develop really many symptoms at all, and these usually constitute the majority of the people. We have a recovery group who start off with high levels of symptoms and get better over time, but we also have this important group who have a delayed onset. They start off with a low to moderate numbers of symptoms, and this gradually gets worse over the 2-year period. So they provide a special challenge for us, in that they won't necessarily be coming forward immediately after the attack, but we need to have ways of finding out who they are and providing services at a later date. So just to summarize, direct victims are at high risk of persistent disorder, with PTSD rates of 20% likely even 2 years after major attacks. Individuals without previous experience of mental health treatment tend to avoid treatment, and delayed onset and delayed help seeking means people will continue to come forward for at least 2 years and probably much longer after the incident. And certainly back in 2005, we knew very little about how to deliver mental health interventions, who takes them up, and whether they are effective. Right, so the next section, I'm going to talk a bit about mental health options in the medium term. Right. Okay, so in the United Kingdom, this was the situation that we had in 2005 when the London bombings occurred. The arrangement was that local authorities should mount an immediate response, including counselling, so that people could come forward who wanted some sort of immediate advice or assistance or somebody to talk to. This was all organised by the local authorities. And it was assumed that persistent mental health needs of the kind we've been talking about would be met by the normal referral channels. So people would go to their family doctors, they would be referred to psychiatric services. mental health was traditionally not represented in emergency planning forums. Emergency planning forums were all about immediate safety. They were about getting people to hospital in ambulances. There was really nothing in the plans that foresaw a later mental health needs and what perhaps should be done about it immediately. And there was little coordination between the local authorities, who had mainly employed social workers, and the mental health providers, who employed more psychologists and psychiatrists, that they didn't share any common framework of training or understanding. There was little coordination or understanding of what each other did and how they should work together after a major incident. So of the various options, until a few years ago, it was assumed that psychological debriefing was the thing that should be done. It's now not recommended because it's seen as too intrusive, and the emphasis now is not on getting people to talk about what's happened to them unless they very much want to do so themselves. So we now talk about psychological first aid. We now try to focus on immediate needs for safety and information. And the aim is to have these five principles underpinning the interventions. So we want to help people to feel safe, to make them calmer, to give them a sense of effectiveness, to help them to feel connected once again to other people, and to give them hope. But not necessarily requiring that they need to talk in detail to anybody about their experiences unless they very specifically want to do that. But also there are other options about media and web-based information strategies, and particularly involving schools, but people at all age groups, so that everybody has access to the kind of information they might need to tell them what the symptoms are they might look for, after what time period they should start thinking about treatment, what kinds of treatment are available, what they should be asking for. Okay, so those are general interventions with anybody who's had any kind of exposure. But also we need to think more particularly about people who are not making a natural recovery. We know that most people will recover naturally, but we also know that there will be a substantial minority who do not. So even though we might generally be reassuring people that most people will have a good outcome, we need to pay attention to identifying everybody who's been affected, so that we can think about in the future how many of them are going to develop delayed onset problems, how many of them are not going to recover from their initial symptoms, what additional treatment needs will they have. How are we going to find these people? How are we going to tell whether or not they're in need of treatment? How are we going to arrange for them to have treatment that works, rather than letting them simply go and see their family doctor and ending up with any kind of treatment that may or may not be really what is appropriate given their condition. So we need to think about also about various incidents, the different qualities of different incidents. Some will affect people who are living in a defined geographical area and who are linked to a known set of health providers. So, for example, in school shootings, it's nearly always known exactly who's been affected and who the health providers are. But if with something like a terrorist incident in a transport system, the population is usually dispersed. They may be coming from very different parts of the country or even the world. They're going to different parts of the country and the world. They're not in this defined geographical area. And in other cases, there may be incidents where we don't actually know who the affected population is, and it may change. For example, in an attack involving poison or radioactive material, the understanding of who has been affected may change quite dramatically as samples are taken from different areas. And for example, prevailing weather conditions may determine what the affected population eventually consists of. So we also need to think about the degree of infrastructure damage. This will affect the ability to people to engage in treatment, because infrastructure damage will probably have to be addressed first, and then psychological needs will be assessed after that. A variety of different roles may be considered. It's important not to leave any of these individuals out. So it's not just direct survivors and the bereaved, but also family members of survivors. For example, children and families of survivors may have their own particular needs. They may be very much affected by the anxiety and depression in their parents. First responders, bystanders, people who are only accidentally present, staff dealing with the injured or dead, for example, collecting body parts or taking samples, journalists and camera operators. These are just some of the many, many individuals who will be eventually affected in some way, possibly by a major terrorist incident. Okay. Right. So what I think is, in many of these incidents, not all of them, but in many of them, there is a strong case to be made for a centrally managed outreach and screening program which can identify the people who have unmet mental health needs, inform them about the thresholds for seeking treatment, ensure that everybody has equality of access to treatment, regardless of where they're living, ensure that standards of care are maintained, and monitor the overall success of the program. And that's really what we did in London for the first time in 2005, was to try to put these principles into practice systematically from the very beginning. So moving on to talk about London, you can divide the response into three phases. First of all, this is what happens immediately. This is the central government response. We have something called the Cabinet Office briefing rooms, in which very senior members of the government meet together with the police and the emergency services and make decisions about the deployment of those services and about what other organizations, what other government ministries need to be involved. In phase two, Westminster City Council set up a humanitarian assistance centre together with the police, the Red Cross and other organizations. So this was a drop-in centre to which people could go whenever they wanted to get advice, to get counselling, complementary therapies, variety of immediate help of different kinds. It's designed to be a very flexible system so that people could use it as and when they wanted to. And then we can distinguish this third phase in which the senior managers of the London National Health Service mental health trusts met and assigned responsibility to my local trust, Camden and Islington, to organise the mental health response. Now, of course, the management really didn't know what should happen, so they turned to us as the clinicians to say, what should we do? So we had a clinician-led proposal that we then had to persuade government that they should support and fund. And based on the review of the literature that I've talked about this morning, we knew that it was very likely that there would be a lot of unmet mental health needs in the future unless we did something about it. And unless I tried to identify people, find them and screen them, we were pretty sure that the same things would happen in London as happened in Oklahoma City or New York City, and people would not receive the treatment they needed. We determined that the existing services did not have the resources to screen and treat people, that there was a dispersed population, they wouldn't all have equal access to services, and that what we argued for was a dedicated screening team in a central location that could coordinate identifying people and monitoring their outcomes and making sure that everybody had access to equivalent standard of care. So the program was essentially a partnership between a number of key organizations who all needed to be involved. And these included the Mental Health Trusts, specialist traumatic stress centres in London, the London Development Centre for Mental Health. So this is an organisation that's part of the National Health Service, but it was specifically designed to help implement policy, to be an organisation that translated between what government wanted and what really happened on the ground with providers. So they had this expertise in communicating between government and clinicians that was very helpful to us in the messages that we wanted to send upwards to central government, but we didn't have the connections or the knowledge about how to go about this process. And they provided that expertise for the proposals that we wanted to put forward. The program was managed by a steering group, and this had again representations from NHS clinicians and managers, the emergency services, including the police, the 7th of July Humanitarian Assistance Centre, the voluntary sector, and the Health Protection Agency and occupational health organisations. And this was really very important, that we had a forum where we could meet with all these individuals and explain what the mental health needs were, so what we needed from these other organisations, and they could tell us what they needed from us. And we could sort out differences in understanding and barriers that were present, for example, between the social services and the health services. We had different expectations, we knew very little about how each other worked, and being able to meet regularly made a huge difference to the effectiveness of the program as a whole. So what we ended up with was a systematic implementation of these ideas about screening and treating individuals. We estimated there would be 1,120 new cases, so we thought about 4,000 people in total had been affected. People in all those different categories I mentioned, the first responders, the direct victims, the bystanders, all the people who've been involved in one way or another. We estimated about 4,000 people would have been affected. When we thought about 28% of them would develop psychological disorders, so we planned for those numbers. We had a centralized screening team, one clinical psychologist, one administrator, 2 graduate psychologists, additional psychologists to do the treatment, provide evidence-based treatment at specialist centers where they were supervised by experts in post-traumatic stress. And these centers used their own local treatment protocols. They were all evidence-based, but they all used the same outcome measurement. So we could compare, we could make sure that we had the same measures available for everybody, regardless of where they had gone for treatment. So the process, first of all, when we located an individual, we sent them a screening questionnaire, or we did one over the telephone. If they screened positive, they came in for a diagnostic interview to find out more about did they have a psychological disorder, and also were they not getting better from it. If they were recovering naturally, we sent them back and continued to keep in contact to make sure they were getting better. But if they had problems and they weren't getting better or they were getting worse, then they were referred for treatment. And everybody who was not referred for treatment was still followed up later and sent further screening instruments to make sure they weren't in this group of delayed onset individuals who were only later developing the problems. So we planned for 4,000 people, but what actually happened in practice? Well, in practice, we only received names of about 910 individuals who we knew had been directly involved in the London bombings. And part of the reason for this was data protection issues that many organizations did not want to give us these names, they felt that they would be breaking the law. I'm sure you do not have such crazy laws in Denmark about data protection. We have laws that, in some ways, they're sensible, but there are situations in which they don't make sense. And the problem in the UK was that nobody had foreseen what these situations would be and how to make sure that what was sensible in one context did not stop making sense in another context. As you can see, of those 910 people, we screened 600 of them. So 2/3 of them actually were screened. 363 of those received a detailed assessment, a detailed clinical assessment, and 304 were judged to actually need treatment. So 304 needed treatment, 278 were referred for treatment within our program, and 189 actually completed treatment. So the figures I'm going to be describing are based on these figures here about the numbers who were treated and actually completed. So 65% of all the people, program users, people who we had information had been involved, were actually screened. Of those 596, over half screened positive at some stage and received a clinical assessment. So, in other words, there really was a big need out there. People were really seriously affected by their involvement in the bombings. And of those 363, 76% were referred for treatment. So you can see they were judged to have needs that were sufficiently severe that they needed treatment. So this I think, illustrates what those earlier slides showed about the really high rates of psychological disorder that you can expect following a major incident. And the likelihood of screening positive was highest when people first came to us. But even on second and third screenings, people who did not at first screen positive sometimes screen positive later. So it's important you don't just screen once, you do it more than once. And the likelihood of being referred for treatment increased as the study went on. So just to show these data, so these were our referrals. So this is when the bombings happened in July 2005. And almost all the referrals have been made to the program by early in 2006. And these big spikes refer to hospitals or other organizations that released lists of names to us at these various points. And then after that, there was a very slow trickle of people being referred to the program. Now, this is referrals to treatment. So of all the people, as you can see, when people were first assessed at the beginning, just after the bombings, a lower proportion of people were judged to need treatment. But as time went on, then being referred for assessment meant they were much more likely to judge to need treatment. So this is the same effect that we saw about the peak of anxiety and distress that first happens in the first few months and then gradually gets better. So a lot of the people here are just having increased distress and disturbance that will recover naturally of its own accord. But when we pick up people later on, after a year or 2 years, then these are people whose distress has not recovered naturally. They are people who, almost all of them, are going to need treatment. Okay. So let's move on. So let's look at the diagnoses. As you can see, the vast majority were diagnosed with post-traumatic stress disorder, but also we had other disorders like travel phobia, adjustment disorders, generalized anxiety disorder, a few cases of complicated grief, and cases of depression. How about the treatment that we offered within our program? Well, 156 were referred for treatment for post-traumatic stress disorder. And of those referred for treatment who met diagnostic criteria according to the DSM-4, as you can see, half were female, half were white British, mean age was about 40 years, and 83% actually completed treatment, which is quite good going. Now, how much treatment did they actually get? Well, this slide shows us that the average number of sessions was about 12. So people got about 12 sessions, each 60 to 90 minutes in length. And the treatment duration was about 24 weeks, so they had one of these sessions roughly every 2 weeks. But as you can see, there's a big spread. Some people got many, many more sessions than this. And these reflect the people who had prior mental health problems, and these provided these were their experience of the bombings, complicated, already long-standing issues. So there were not too many of those, but those that there were needed a really much, much longer intervention than the majority who could be treated within 12 sessions. And if we look at our outcomes, basically, for those of you who are familiar with these instruments, this is the post-traumatic diagnostic scale of Edna-Foa. This is the Beck Depression Inventory. All you need really to know is that the outcomes were extremely good in the sense that the sort of recovery rates we got were equivalent to what we find in the literature when there are randomized controlled trials being conducted of evidence-based treatment for depression or post-traumatic stress disorder. So the amount of improvement found in those trials in the literature, we were able to replicate within our sort of natural sample in this very practical situation. So in other words, there's evidence that you can certainly apply the treatment protocols that are evidence-based, that they seem to work very effectively in these situations. And it shows that about 62% of individuals showed really substantial, clinically significant change on this measure of post-traumatic stress. And this is amongst all the people who were treated, whether they completed or not. And amongst those who completed treatment, it went up to 66%. So these are really pretty good figures compared with what you can expect from treatment of post-traumatic stress disorder. Okay, let's press on to the final section on what we learned from this whole exercise. People in Britain were very worried that thought that we were going to phone people up and write to them and say, how are you doing, answer these symptoms, how has the bombings affected on you? In Britain, people thought people will not want their privacy to be intruded upon. They won't want their National Health Service contacting them. They were quite wrong about that. People wanted their National Health Service to contact them and ask them how they were doing. And when we phoned them up, they said, what took you such a long time? So all sorts of myths about, in the upper echelons of British society about what British people want, which often are quite wrong. But what we did find is that that personal contact was very important. The police did not allow us, for data protection reasons, they did not tell us all the names of people they knew about. So police lists of people, the police wrote to them on our behalf, sent them letters about our program, encouraged them to contact us. But when we followed this up, we found a lot of them had not remembered getting any letters. They'd not received treatment often, even though they had real needs for treatment. So this third-person way of contacting people was very unsuccessful. And so I'd strongly recommend that the personal contact is very important. The people didn't mind their contact details being passed to the National Health Service. They wanted this contact, and their local family doctors often were not aware of services and were often not very helpful to them. So there were a lot of complaints about family doctors. So in other words, our program was necessary because the ordinary services were not meeting these needs. They were not identifying the problems, they did not know what to do about it, hence the importance of the outreach and screening. So the clinical providers said that, pointed out that if you rely on the ways in which people normally get health care, these are usually very inflexible. Certainly in the UK, I'm sure things are much more flexible in Denmark. But in the UK, you have to go to a certain hospital, you're allowed to go to. There may or may not be someone who has special expertise in the area that you need living locally. There are all sorts of rules about who pays for this, who is allowed to do that. These things make sense for the normal situation, but they are a disaster when there is a major incident like a terrorist disaster, because they prevent people from having free access to what they really need. And this is what happened in London. So institutional barriers, also about conveying of information, was a major problem for us. We needed to set up new contacts with organizations and people that we didn't know who were involved in emergency responding. These were not usually in place. And making contact with other parts of the UK was often difficult. Okay, so that's 50. So let's try and finish quite, just got a couple more slides. So if you have a dispersed population, they fall across boundaries in unpredictable ways. So it's quite difficult to make plans for them in a health service terms, because the health service usually operates according to, well, we have this number of people living in this district, and these health providers are there for them. And they're not very good at crossing boundaries, which sometimes you need to do in these situations. Even the computers perhaps will not recognize people who come from a different area. So you can't accept people because your funding mechanisms in your computer systems are not set up to do that. The central organization seemed to be really important, so there was someone in the middle who could keep track of all the things that were happening in every part of London and in different parts of the UK. And nobody was quite sure who owned our program. Nobody really stood up and said, well, we're going to take responsibility for making sure this is successful and that somebody provides the money for it. When it came to funding it, nobody really wanted to say, that's us. You can look to us for the money. They said, oh no, look to somebody else. Or, well, we'll tell you in a year or two how we're going to pay for it. I'm sure things are completely different in Denmark. But certainly in the UK, there is no provision for something that happens that is unexpected. Nobody knows how to pay for it. So this is always a major difficulty. So really these are questions for all of us you in the audience as well, that from our work, these are the questions that we would suggest you might want to think about, or you might want to say, well, do I know the answer to this? Is this question relevant to me? So who is responsible for mounting the immediate response to a terrorist incident, addressing immediate psychosocial needs, and providing counselling for those who want it? Is anyone responsible for identifying all those affected and holding a central register of all those affected? And in the UK, now the Public Health England have been charged with this responsibility. Are there data protection issues that are going to prevent them from carrying out their work? Are plans in place of how you will screen those affected to identify mental health problems and treat them? Are the people who will do this screening closely connected with all the other organizations who will be responding in the emergency? And will your current arrangements for care pathways, will they help or hinder patients' access to treatment? What alternative pathways need to be prepared for in the case of an unexpected incident? And finally, and most importantly, who's going to pay for it? Okay. No, thank you very much.
Thank you, Chris, for a wonderful presentation. We now have 5 minutes for questions. If anyone in the audience wants to come forward with questions. Yes, Louise? You need a microphone there.
Okay, nu virker den. Your first slides regarding the effects on PTSD from the people who had been exposed, you had one slide that showed that within the one where you were putting it in order according to how fast after the incident did they see these people. You had one showing that it was almost down to 0 when it was 3/4 of a year later. Yes. And then you had the other slides showing that it was close to 30, 2 years later, and then you concluded that it was actually a risk of 20%. And I didn't quite get the difference between these different
Yes, the first slide was about the general population. So people who live in the country or in the city but are not directly affected by the terrorist incident. So in New York, for example, these were people who lived north of Canal Street. And the second slide were the people who were directly affected. So in New York, these are people who live south of Canal Street, close to the World Trade Center, or people who were actually present, who actually witnessed the scenes, who were bystanders, who were members of the emergency services. So they're two very different groups of people.
And how did you end up with the 20% then, as the concluded?
Yes, those are the people who were directly affected. And the data suggested that even after 2 or 3 years, 20% of those who had been directly affected were likely to have persisting mental health needs.
Yes, it escaped me what kind of treatment they got. Was it trauma-focused CBT?
The majority got trauma-focused CBT. Some got EMDR. Some got a mixture of the two. So we didn't tell the centres how they should deliver the trauma-focused CBT. They all had their own slightly different treatment protocols, but it was all basically trauma-focused.
Mm-hmm.
Yeah.
There was another thing that escaped my attention. We talked about ITT and TC conditions.
Yes, those first of all, the intention to treat.
Okay.
And treatment completers. So that your outcomes for people who are all part of the program, regardless of whether they complete treatment or not, are never as good as for the people who actually complete all the treatment they've been assigned to.
There was also one more thing about the number of PTSD cases according to DSM-4 and ICD-10. There are 4 times more if you use the DSM-4 system.
I think there were perhaps about 20% more using ICD-10. ICD-10 seemed to be slightly more lenient than the DSM-4.
I read the numbers and 126 with DSM.
Can you please use the microphone?
Yeah. It's just I'm being insecure about the number of PTSD cases with one diagnostic system or the other, if there was a huge difference.
Yeah. No, I think my slide was not very clear. If I can explain it. This meant that 126 people met criteria for DSM-4 and ICD-10 PTSD, but an additional 30 people met criteria for ICD-10 PTSD, but not DSM-4.
I get it.
So.
Thank you for a very interesting lecture here. My question is about the effect sizes.
Yes.
Of course, you couldn't have a control group in this case. So my question is, what about spontaneous recovery? How could you differentiate?
Yes, in a study of this kind, you cannot evaluate what the effects of spontaneous recovery are. And all the effect sizes are within, they're pre-post within the same individuals, so they're not based on a comparison with a control group. But we've compared them with other similar effect sizes reported in the literature and shown that they are similar to those, where they have used a control group. So I think, unfortunately, when you're trying to mount a response to a major incident like this, the political reasons mean that it's almost impossible to do the kind of study that you and I might want to do. That the politicians who are providing the funding are not going to agree to a randomized controlled trial. So you have to do the best you can.
One gentleman over there and Cecil up there. We have to finish in 1 or 2 minutes.
Okay. Hi. In the beginning, you dismissed debriefing as a part of the help proposed to I guess it's civilians. Is that based on the Cochrane report, or is there some other research that you're concluding this on, or you're basing this dismissal on?
I think it's based really on the absence of any positive data showing that it's helpful, and some individual reports showing that for certain individuals it may be actively unhelpful. So I think in the main it probably does not make too much difference one way or the other, and I'm sure there are some people who feel that they benefit from it, from receiving it. But I think if you're thinking about where you're going to spend your money, what is the most effective way of spending the resources you have, the evidence suggests debriefing is not the way to go. That you could perhaps spend fewer resources on this immediate response and spend more on the people who you know are not going to get better. So make sure you don't miss the people with the persistent disorders, who are the ones who really need the resources, by providing things immediately for where most of the people will probably not need it. So I think there are there's an economic argument, there's also a practical argument about how useful is it likely to be.
Thanks.
I know there are more people here in the audience who would like to ask questions, but I think we have to stop now for a break, because at the end of the day we have a...
I kan skrive på Nannas mail. I kan skrive på Nannas mail. De kan skrive på Nannas mail, og så tager vi det til sidst.